We're just thrilled this morning to welcome Dr. Briggs and Dr. Luetkemeyer. Dr. Jessica Briggs is an assistant professor in the Division of HIV, ID, and Global Medicine, who directs the Hepatitis C clinic embedded into Ward 86, and also has expertise in malaria epidemiology. Dr. Annie Luetkemeyer is a professor in our division who is an expert in the treatment of viral infections, globally renowned, also has a Wikipedia page I learned this morning, who directs numerous clinical trials related to hepatitis, HIV, COVID-19, as well as STI prevention. I am just so excited for them to take us through a number of case-based vignettes related to co-infection. So as a reminder, log into polev/HIVGR to participate in the room and online. Thanks.
I did not make the Wikipedia page, so it just showed up, but there it is. So Jess and I wanted to really just go through some practical cases and thought experiments that come up a lot. So we're going to cover a lot in this hour. We're going to start with hepatitis C and then shift over to some hot topics in hepatitis B. These are our disclosures. So just to set the stage, how are we doing in Hep C elimination in the United States? We hear a lot of talk about this. The former head of the NIH, Francis Collins, has taken this on and is trying to get a big, package through Congress, which is really exciting. And one of the really important targets, right, is I'm not going to go through the other three, but how are we doing in reducing the number of new hepatitis C infections per year? Well, not well is the answer. Or we're not on track for our goal, and we're actually going in the wrong direction. So you can see that hepatitis C viral infections are going up and up. So that is not what we want to see. That's a real problem. And we're not doing great in the other areas either. Spoiler alert. So we have a highly effective cure for everyone with hepatitis C. There are almost no people that I can think of who cannot be cured if they can put the pill into their mouth. Some people can't put the pill into their mouth, but this is a huge advance. This is one of the biggest medical advances that we've had in the last, several decades. It's just not reaching enough people. So these are some recent data from the CDC that show that 1 in 3 are cured overall. 1 in 4 are cured if they don't have health insurance. 1 in 4 are cured under the age of 40, and 1 in 6 are cured under the age of 40 without insurance. And there are more and more disparities that you can dig into here that you can imagine, where we are not doing a good job of reaching people. I'll just say this can be done. There are countries and cities and many examples of how we can do a much better job. So, and many of those places are not resource-rich settings. So we wanted to set the stage for our discussion about hepatitis C with this framework in mind that we can treat people, we should treat people, and it's actually really easy, and I would put in parentheses, fun to do. So Jess is going to take us through a couple of cases, really focusing on a low barrier access. We're super excited about the HAPS opening, and that we're hoping that the HAPS will be a real hub for hepatitis C diagnosis, linkage, and curing people, because it's one of the very few things we can cure, and it's one of the things that we absolutely should. So I'm going to turn it over to Jess.
Okay, so what are these so-called HAPs? These are status neutral places that the San Francisco Department of Health is establishing so that people can have access to low barrier healthcare. And one of the pillars of this is to decrease barriers to HIV and hepatitis C testing, linkage, and cure, as Annie was stating. And they're going to be, not just providers are going to be available there, but also multidisciplinary teams, including social work, substance abuse teams, and really hoping that this multidisciplinary team approach can ensure continuity of care and result in great outcomes for patients. So if the goal is to integrate low barrier hepatitis C care into the HAPs, what constitutes low barrier care for hepatitis C? Like, how could we make it easier? Does anyone have any just quick ideas? Just like shout them out. Treat right away. Treat people where they're at. Treat right away. Don't wait for a genotype. Speed up the laboratory process, right? So here's just a few things I could think of, like right off the bat, of how to lower the barrier to care for hepatitis C. If we could immediately do hepatitis C antibody testing and a venipuncture draw the same day if that antibody point of care test is positive, fewer monitoring visits with fewer labs, immediate access to hepatitis C therapy if you are RNA positive, and then shorter therapy and fewer visits to pick up the medication. All of these things would help someone get on treatment, hopefully stay on treatment and complete treatment. So we're going to talk about a theoretical case of a 25-year-old man presenting to a HAP. He has a history of IV drug use, and he's living with HIV and taking Biktarvy. And he presents to the health access point, and he's told that his hepatitis C antibody was positive at his initial visit. And at this visit, you're actually sending the viral load and the genotype. And he reports that he's never been treated for hepatitis C. And he's like, oh, okay, I didn't realize that the treatment was so that almost everyone is cured. He's really excited about that, but he is worried about the number of extra healthcare visits involved. And so for our first audience response question, I'm going to ask you which patients are not eligible for simplified treatment under the 2023 IDSA AASLD guidelines. So is it A, patients with genotype 3 infection, B, patients with any genotype besides 1A, 1B, C, patients who have a history of Hep C treatment but did not achieve a sustained virologic response or SVR, D, patients with compensated cirrhosis, or E, patients with HIV. Is it working? Okay. All right, so we'll just move on because I think we're having a little bit of trouble with the audience response questions. But the answer is C, patients who have a history of hepatitis C treatment but did not achieve SVR. So just a note, now under these new guidelines, all genotypes are eligible for a simplified treatment algorithm. In fact, if you have compensated cirrhosis, which means Child-Pugh class A by that scoring system, then you are also okay to proceed under the simplified treatment guidelines. And patients with HIV are newly eligible for the simplified treatment guidelines, algorithm in the 2023 guidelines. So that's a change from prior. So what does this mean? It means that treating people on the simplified treatment algorithm has become even simpler, really. So if you have hepatitis C, chronic hepatitis C, regardless of whether or not you have HIV, and you can be infected with any genotype, and you have not previously received hepatitis C treatment, and you don't have cirrhosis or you have compensated cirrhosis, you can be treated under the simplified guidelines. So what excludes you from the treatment, the simplified treatment guidelines? So here it says previously received hepatitis C treatment, but what we interpret that to mean is previously received hepatitis treatment and failed. So we would note that if you have received hepatitis C treatment and you were cured with documented SVR, that you are, as the next time you were infected, that would be a new infection, that would be a reinfection, and you would still be eligible for treatment under the simplified treatment algorithm. So we added previously received hepatitis C treatment and failed to that, what is written in the guidelines. If you have a hepatitis B surface antigen, which is consistent with active hepatitis B, then you are not eligible for treatment under the simplified guidelines. Compensated cirrhosis with end-stage renal disease, decompensated cirrhosis, current pregnancy, known or suspected hepatocellular carcinoma, or prior liver transplantation will also rule you out for treatment under the simplified guidelines. So what do you need to do before you treat someone in non-cirrhotic patients? So first, you can just calculate a FIB-4 score to assess for fibrosis or cirrhosis. You really do not need to obtain liver imaging before getting these patients started on therapy. You need a CBC, hepatic, and renal function panel within the last 6 months, but you do not need one that was drawn on that day right before starting treatment. It's very important, I would say, maybe it's one of the most important things to do a thorough med rec and assess for drug-drug interactions. And I feel like this is something that can be intimidating for providers, so I'm going to discuss more about that on the next slide. You need to make sure, of course, that they have active hepatitis C. I mean, typically when you're thinking about treating someone, you already have checked that. But if you haven't checked it recently, you would probably want to have an active one within the last 6 months to a year. And then, of course, we talked about the hepatitis B surface antigen. If the person is a reproductive age, you'd want to do a pregnancy test if appropriate, and then counsel on adherence and provide linkage to navigation services. So medication reconciliation and assessing for drug-drug interactions has really been made a lot simpler by use of this tool that's sponsored by the University of Liverpool, interaction checker. So you can just Google Hep C Liverpool interaction checker. That's how I get there. I don't have this website memorized, but it is the first thing that pops up. And for the hepatitis drugs, you can actually put in you can spell them by brand name, which is nice. And then if you put Mavorite, like Glipib will pop up, and if you put Epclusa, Sofvel will pop up, because I think it's hard to remember those names. For co-medications, you do need to know the generic name. It's not going to register the brand names. And then one by one, you can check and see if there are any drug-drug interactions with the patient's medications and the 2 hepatitis drugs that you're most likely to be considering treating them with. So what about monitoring? What monitoring is required under the simplified treatment algorithm? None. For most patients, no laboratory monitoring is required. And that's really awesome. And I think is like undersold part of this simplified treatment algorithm. So there are exceptions to this rule. If a patient has diabetes, then you would want to counsel them that they need to be aware that they may experience hypoglycemia, although I would say that that's pretty rare. And of course, if someone's on warfarin, then you would want to monitor their INR. And every patient, of course, is going to need to be assessed for SVR at least 12 weeks after completion of therapy. So this is documenting that the cure worked and making sure that you know that the person is cured. So another thing to remember is that if the person has AST, ALT elevation at the beginning of treatment, then you need to check a liver function panel at the end of treatment to ensure normalization of AST, ALT. And if it has not normalized, then you need to look for alternative etiologies for transaminitis. So maybe you're telling me, oh, I believe that simple patients don't need a lot of monitoring under the simplified treatment algorithm, but it's hard for me to believe that my HIV positive patients, can have this little monitoring. It makes me worried. Well, I can tell you that there is some studies to back up the addition of HIV positive status to the simplified treatment algorithm. And this data is given to us by the MinMon study, in which 400 patients were enrolled. 399 initiated Sofvel treatment, so that's Epclusa. There was no pretreatment genotyping. All 84 tablets, so the full 3-month course, was dispensed at entry to the study. There were no scheduled clinics, visits, or labs required. And there was just a remote visit at 4 weeks to check on adherence and ensure that they weren't having side effects, and a remote visit at week 22 to schedule SVR. So what was the outcome of the MinMon study? So 42% of those enrolled were living with HIV, and the rates of SVR were almost exactly the same between those living with HIV and living without HIV. So we have shown through this study that minimal monitoring works very, very well to achieve very high rates of SVR, both in patients living with HIV and living without HIV. And if you're worried that maybe your HIV patients are on more medications and you're worried about more drug-drug interactions, again, those can be managed just by doing a thorough medrec. And there have been studies showing that patients living with HIV really don't experience higher rates of adverse reactions to the medications or drug-drug interactions than those living without HIV. So that's why the guidelines were updated in the 2023 guidelines. So what about patients who use injection drugs? And do we feel comfortable with a low barrier start and low monitoring approach to those patients? And so here I'm going to feature a study that was run by some UCSF investigators, Jenny Price and Megan Morris. And they ran a really unique study, I think. It was conducted at a fixed community space and through a mobile medical van. So not a truly medicalized clinic-based setting with providers. And they enrolled individuals 18 years or older who reported injecting drugs or a history of blood transfusion before 1992. The median age was 48, 71% male, and fairly diverse for the city of San Francisco. 61% of patients reported being homeless in the past year. 97 were living below the poverty line. 80% reported current IVDU. And interestingly, 94% had health insurance. But only 48 had a PCP. And in the paper, they note that we live in a Medicaid expansion state, which accounts for the 94% having health insurance. So what did they actually do? So at the very first visit, they did a finger stick with a rapid hepatitis C antibody and an HIV antigen antibody point of care test. And if the patient was hepatitis C antibody positive, then they immediately drew blood and sent it off for hepatitis C RNA with reflex genotyping. And they collected insurance information as well, and just to get the process started for prior authorization for Hep C meds. The second visit, they disclosed the results of the hepatitis C RNA. And if you were RNA positive, you were immediately enrolled in this now study if you agreed. They would send any additional pre-treatment labs that hadn't been sent before. They would give you counseling on adherence and immediately give you the first 2-week starter pack to start taking treatment. And in this, they also use Sofvel or Epclusa in this study. And then they would immediately help you with prior authorization. And if you were approved, you would get your medications through insurance. But if not, they would continue to provide medication every 2 weeks through starter packs. And so you could be excluded from the study, quote unquote, late exclusion. If they drew your pre-treatment tests and something concerning came back, that might make Epclusa less of a good choice. But actually in the study that they ended up not having to exclude anyone using the late exclusion criteria, which is great. Oh, and just to note, they also provided incentives. So the one thing about this that is a slightly less real world, possibly, depending on the resources of your community, is that they provided incentives on each visit. And I would say that this model of care was remarkably effective. So let me see if I can point with this. Yeah. So this flow chart's a little confusing because only 50%, whoa, sorry. Did I do something? Okay. All right. Anyway, there were very, very high, here we go. 98% of eligible patients initiated hepatitis C treatment at the point of diagnosis. So this is the people that returned to get their hepatitis C RNA result, and then 98% of those initiated hepatitis C treatment. Of those who completed therapy, about 80%, started therapy, about 80% completed therapy. And of those who completed therapy, 92% were undetectable at treatment completion. And then of those undetectable at treatment completion, 95% achieved SVR12. And they noted that they think there are 2 people that actually were reinfected very quickly because they had been negative at the end of treatment, but then were positive again when SVR was checked. So I think this study is great. It shows comparable SVR12 rates to the HERO study, another study in which people who use injection drugs were enrolled. In that study, they were enrolled at opioid treatment programs and community health centers, so more of a clinic-based approach. And they noted that this model of care actually led to higher treatment initiation, probably because there were just less visits and less barriers involved to getting on treatment. Late exclusion, as I mentioned, was possible for lab test results or a genotype 3 plus cirrhosis result, but no patients actually require treatment adjustment, which means that I think this approach could really be used in the community because very few people would be excluded based on their laboratory results. One gap that was identified is that 20% of people who were hepatitis C antibody positive did not return for their RNA results. So really every single visit that's required is a barrier. And so trying to reduce that as much as possible is really important. All right, so I think I've hopefully convinced you that minimal monitoring is possible in nearly all patient populations, and definitely in all patient populations who qualify for treatment under the simplified treatment guidelines. And so, okay, you're ready to treat someone. What do you treat them with? And I think most people are familiar with these drugs by now. But their names are very hard to remember. So I'm not even going to try to pronounce the full viral names, but it's Glipib or Mavyret and Sofvel or Epclusa are the 2 pan-genotypic regimens that we primarily use these days for hepatitis C treatment. They're both extremely effective. And the main differences between them are their drug-drug interactions. They have different drug-drug interactions that you can, again, check using that Hepatitis C Liverpool website. And then the duration of treatment. So Mavyret is 3 pills once a day for 8 weeks, and Epclusa is 1 pill daily for 12 weeks. And patients often, express a preference based on either pill burden or duration of treatment. And they're very, very well tolerated. There are some patients who report some nausea, GI symptoms, and fatigue, but in general, I would say that like the vast majority of people don't report any symptoms at all. So we're going to talk about a slightly more complicated case now. This is a 52-year-old man who has HIV, also on Biktarvy. He has hepatitis C genotype 1B. He has never been treated before, and he has known cirrhosis by both FIB4 and imaging. But it is Child-Pugh class A, and he has no history of hepatic decompensation. So he says, I want the shortest treatment that's humanly possible. And you're like, all right, well, the question is, what would you give him? Would it be Glipib times 8 weeks, Glipib times 12 weeks, that's Mavyret, Sofvel times 8, or Sofvel times 12 weeks, or refer him for a transplant eval before treatment? And we'll see if this works. It's not going to work. All right, let's raise hands for A. Glipib times 8 weeks. Got a few hands. We got a lot of hands. Okay. Glipib times 12 weeks. Sofvel times 8 weeks. Sofvel times 12 weeks. Oh, people really went all in on A, which is the correct answer. So, but this would not have been the correct answer according to the prior guidelines, right? So previously, those who were hepatitis C and HIV co-infected would actually have to get 12 weeks of Glipib, which would make it the same duration as Sofvel. But now with the updated guidelines, it is possible to just do 8 weeks of Mavyret in co-infected patients. So that's a really big improvement. And of course, D would be technically a correct answer. It would be a possible way to treat them, but would not be the shortest. So this person has compensated cirrhosis. And what are the differences in pre-treatment, on-treatment monitoring, and post-treatment when someone has cirrhosis, right? And so I think the most important thing that you have to remember is that because they have cirrhosis, they do need monitoring to surveil for hepatocellular carcinoma. The guidelines state that you should perform a liver ultrasound, prior to treatment, because you're supposed to look for HCC before you start treatment. I would say that I wouldn't let this stop me from starting treatment, but you need to remember that this person needs to be surveilled even after treatment every 6 months for hepatocellular carcinoma. And then on treatment monitoring, you just need to let the patient know that there are very rare cases of liver injury during treatment, like rarely hepatic decompensation can occur. So you can counsel patients to report jaundice, ascites, encephalopathy, et cetera. And I'm not going to talk about it today, but I just want to, make it known, of course, that even patients that have decompensated cirrhosis and hepatitis C can be safely and effectively treated, but generally that's done in conjunction with a liver specialist or hepatologist. And there's additionally, I'm not going to review this in depth because I think this is just so case by case based. But in reality, especially when you're starting people on care, on treatment with like low barrier to starting treatment, you may experience treatment interruption with your patients. And before now, there was no published guidelines on how to deal with treatment interruptions in hepatitis C. And Annie and I would generally be involved in these cases. And we probably still should be, but that now you don't need to talk to us before knowing exactly like the first steps of what to do, which generally are obtain a hepatitis C RNA test immediately. But the duration of how much therapy you've gotten, and then how many days you've missed of therapy, all of those things matter. And you can just follow these flow charts to know what the best next steps are for your patient. So this is now available to you in the 2023 guidelines. And now I'm going to talk briefly about hepatitis C and pregnancy. We reviewed a case very similar to this in our last grand rounds, but there have been a lot of questions about cases in pregnancy and postpartum cases recently. So we just wanted to go over this again. So this is a 23-year-old woman who's 12 weeks pregnant. She's admitted with a urinary tract infection, offered routine HIV, STI, and hepatitis C testing. And she's very confused. She's like, why are you testing me for hepatitis C? I thought that was a disease of the boomers. And you're like, no, actually, it is now a recommendation through both the CDC and the US Preventative Services Task Force to test, of course, everyone at least once in their lifetime. But for pregnant women, it's actually recommended to screen every pregnant woman during each pregnancy. So not just the first pregnancy, and that counts as your lifetime screening. You should actually be screened each time during pregnancy. So you can tell the patient that that's why you're testing her. And then we have one more question. Which is true about hepatitis C in pregnancy? Is it A, no oral medications are approved during pregnancy, but you can give peg interferon and ribavirin? B, Harvoni has been associated with a 75% cure rate. C, spontaneous clearance has been reported in up to 10% of women postpartum. And D, the rate of mother-to-child transmission of hepatitis C is approximately 30%. A, anyone for A? B, Harvoni? C, spontaneous clearance, as documented. I saw like some hand waves. And D. All right, so I think we have like 3 votes for C, which is the right answer. So spontaneous clearance has been reported in up to 10% of women postpartum. A, there are no oral medications that are approved during pregnancy, but peg interferon, ribavirin are definitely not a good option. We'll talk more about what oral medications are possible later, because as B states, I'm just going to say Harvoni. Harvoni has been associated with 100% cure rate in 2 small studies of pregnant women. And then the rate of mother-to-child transmission of hepatitis C is approximately 5 to 15%. So why is this important? And why do we care so much about hepatitis C infection in pregnant women? It's because they represent actually a significant proportion of those infected with hepatitis C worldwide. And this is really a population that we should be screening during pregnancy and treating as soon as possible. Pregnancy is also a time when women touch the healthcare system more frequently, and would be a really good opportunity for linkage, for diagnosis and linkage to care. And here you can see on this bottom chart, like the difference in hepatitis C diagnoses per 1,000 deliveries in women with and without opiate use disorder, and how much higher it is in women who have opiate use disorder. So this is a really at-risk population that we should be aggressive about screening and linking to care. And our colleagues in hepatology have been thinking about this a lot, and really wrestling with the pros and cons of treating someone with direct-acting antivirals during pregnancy. The major downsides are that human safety in pregnancy is not fully established because there have been no pregnant women enrolled in large-scale clinical trials. And likewise, there's very little data about safety during breastfeeding. And sometimes it can be difficult to access treatment during pregnancy and finish it and not drop out of care. And the cost effectiveness of this has not been established. However, I think there are some good arguments for treating patients during pregnancy. You can achieve maternal cure while the patient is engaged in pregnancy care. You could imagine that there could be a possible decrease in mother-to-child transmission and in hepatitis C associated adverse pregnancy outcomes. And of course, women who are pregnant and or recently gave birth often have more insurance coverage. So this is also a good opportunity to treat them for hepatitis C. And of course, anytime you treat someone who's infected, it decreases community transmission. So we are treating pregnant and breastfeeding patients using shared decision-making. So the 2023 IDSA ASL-ALD guidelines say that even though there is no approved oral medication regimen, that you can treat patients in conjunction with shared decision-making between the provider and the patient. And why is that? That's because there is some limited data available on safety and efficacy using soft-bel and soft-lead in pregnant women, so Harvoni and Epclusa in pregnant women. These are very small studies, and they always start treatment in the 2nd or 3rd trimester, but they have those who start and complete therapy have very high SVR rates. We do not use Mavyret in pregnant women because there's no clinical data available. And of course, there is an ongoing phase 4 multicenter study of Epclusa for the treatment of hepatitis C in pregnancy. And I suspect that we'll have data for that by the end of 2024 or mid-2025. So breastfeeding patients, and treating postpartum women, again, you do this through shared decision-making with the patient. Although I do think that there's less risk in this category. So the risk of mother-to-child transmission is overall very low. It's about 5%, but it is higher in patients who are HIV positive, about 10%. And so one of the pieces of advice that we give is that you should avoid breastfeeding if you're frankly bleeding or have severely cracked nipples. But overall, we think that there's very little evidence that there's much excretion of glipib or Sofel in breast milk. So either are okay for treatment in breastfeeding women. You won't find this information in the package insert, but there is some data available on this. So overall, we have started treating these patients if they express that they're interested in being treated. And it's a really great time, I think, to take advantage of the fact that the patient is seeing the healthcare system more frequently than they might otherwise. So please reach out to Annie and I if you're interested in starting treatment in a pregnant or postpartum breastfeeding patient. So one last slide from me, and this literally came out a couple of days ago from the CDC, is that they're updating their perinatal testing for hepatitis C guidelines. So as Annie showed at the beginning of this talk, rates of acute infections have been actually rising, unfortunately, and they've tripled among reproductive aged persons. And of course, because acute infection leads to chronic infection, this has resulted in increasing rates of hepatitis C infection during pregnancy. And so the CDC is updating their recommendations for testing in perinatally exposed infants and children. And the main update is that perinatally exposed infants should receive nucleic acid testing for hepatitis C RNA at age 2 to 6 months in order to identify children whom chronic hepatitis C infection might develop. And then if they are not screened at that point in time, it gives guidelines at the older ages as to when they should be screened. All right, and I'm going to switch it over to Annie for talking about some hepatitis B cases.
Thank you. While we're switching, there are a couple of great questions in the chat that I might just ask you to echo, Annie, if that's okay. Someone asked what the status is of point of care HIV, HCV viral load testing, if you want to just cover.
And I answered in the chat, but so as we know, these are available outside of the United States, including the Cepheid finger stick. It's been a real, I think, shortcoming of the FDA that they have not facilitated getting this done. And there's a real push right now to actually, as part of the elimination, do a study. And there's one that's being sponsored by RADx that we hope to be part of to finally get FDA approval of a point of care or near point of care finger stick test, because they exist, they work well, and we really need one. So there was one other question. Oh, there's another question about like how well is Sofel tolerated or soft lead during pregnancy, and there's 2 small studies well tolerated, but clearly we need more.
Any questions from our audience about the first 3 cases? We can take some at the end too. Thank you.
Thanks, Jess. Okay, so we're switching gears to dual therapy, talking about hepatitis B. So I'm going to give a case, and I actually just got emailed about this by a provider, and this is the exact case. I kept trying to make it cleaner, and then I thought, no, I'm not going to make it cleaner. I'm just going to tell you exactly the case because it was hard. So if 48-year-old gentleman struggled with ART adherence, his viral load is 56,000. He just recently restarted Triomec, but has been on and off, and it's just been hard for him. He wants to start long-acting Cabril as an alternative. He has no resistance mutations that would preclude him from going on Cabril or continuing Triomec. His T cell count, unfortunately, is 64. His viral load was 56,000. He has normal renal and liver function. You check his hepatitis B labs as is suggested by the SPLASH team, which really appreciate. And they have he's a core antibody positive, surface antibody negative, surface antigen negative, Hep B DNA negative, and because you want to be comprehensive, his hepatitis A antibody is positive, so he's immune. That's good news. And his Hep C antibody is negative. Just of note, he got the Hep B vaccine one time back in 2014. So what do you do for this gentleman? And I broke the audience response. This is my fault. I apologize, Joe. So just raise hands. Switch him to Cabril and just add oral tenofovir because you're worried. Would anybody do this? Okay. Switch him to Cabril and just monitor his LFTs regularly. Okay. Switch to Cabril and don't worry about it. I'm too much of just a worry wart and just let it go. All right. Vaccinate for hepatitis B and wait to switch to Cabril until he's surface antibody positive. Don't switch him to injectables. Keep him on, switch him to an HBV active all oral tenofovir containing regimen. That's not what he's on right now. Triomec. Okay. Something else? Anyone else want to throw out something else? All right. What would you do? Okay. Got it. Got it. But would you wait to switch him? You would not wait to switch him. Okay, great. Okay. I'm going to come back and give what I think after I give you some interim data, but I promise that slide is coming back. I know Diane is always a big fan of the summary slide. And I think it's a great one too. So I think there's 3 pieces of data that I want to just highlight. There's more than this out there, but these are new, and I think have really sort of encouraged us all to think a little bit more about where things stand for our patients. Mostly because there's a lot of switching to non-Hep B active regimens. So this was presented at ID Week. This is a veterans cohort of about 60,000 people, and they took 20,000 people who were core antibody positive. And they created an at-risk cohort. So they captured people who were switching to ART without Hep B activity, and they defined this as no tenofovir, lamivudine, or emtricitabine. There's kind of 2 different definitions that I'm going to talk about along the way. Some people define no Hep B activity as just no tenofovir at all. But here they said no tenofovir, lamivudine, or emtricitabine, and at risk for Hep B reactivation, and because they were core antibody positive but didn't have active hepatitis B. They were surface antigen negative and Hep B DNA negative if checked. They didn't check it in everyone. You know, that's a limitation here. And that worked out to about 6,000 people. And they looked for hepatitis B activation defined as new surface antigen positivity or new DNA positivity. So they had 89 reactivation cases among 5,000 people. So that's small, 1.5%. They didn't have all the data they wanted on all of them. So in the confirmed cases of those who continued ART without Hep B reactivation, that was less than 1%, so 7%. But of those folks, it's just worth keeping in mind that some of them, you know, had quite a presentation. You know, the ALT was quite elevated. Several of them were hospitalized, and it wasn't due to mental health admissions. And one of them was associated with hepatitis C treatment with direct-acting antivirals, which we know we need to monitor carefully if people are at risk for reactivation. It doesn't mean we shouldn't treat them. It just means we need to keep an eye on them. So 2 things I want to point out about this cohort, about who's at risk. And you might want to just focus on the far right column, because this is in the people who they know remained on Hep C, on Hep B, non-active ART. They weren't sure about the people in the column on the left-hand side. So who's at higher risk? Ever surface antigen people who were never surface antibody positive, right? Remember, these are all core antibody positive people, and they're all surface antigen negative. So one thing that this was a good reminder for me is just look back in the chart if you can and see if they were ever surface antigen negative, positive. We can do that more now with EPIC, and it's just helpful to know. And that was a group that was slightly higher risk. Again, these numbers are small. And then the second thing I would say is, of this group, which is the gentleman that I described, so let's say he was never surface antigen positive. These are the core antibody positive folks. You know, you still are seeing a risk of reactivation. So they had, 16 in one group and 18 in the other group. And some of them were never surface antibody positive, and some of them had been surface antibody positive in the past, and that had waned, but they still remained at risk, although at lower risk. The risk is low, but it's not zero. So I think that's why I wanted to bring up and have it on our radar for today. Another study that just came out, it was presented at EECS, which again took the same sort of approach. This was a snapshot of an Italian study, and they had 9 isolated core antibody patients switching to Cabril. Most, but not all, had Hep B DNA that was undetectable. It wasn't tested in one. And again, they're just showing that one had Hep B reactivation. And this gentleman did have an undetectable Hep B DNA at the time of switch. And within about a month and a half, he had LFT bump, he had Hep B DNA that went up, they added on FTC TAF, and then they switched him back to oral, and things suppressed. But again, this doesn't give us a denominator of how often it happens. It's probably infrequent, but it can happen. Yeah, okay.
Sorry, and in that first study, for all of those patients, they would have Hep B DNA negative, or is that?
When it was tested, we don't know, but they were all surface antigen negative, but they didn't have Hep B DNA in everyone. Yeah. But they included it if they did have it. And the Hep B surface antigen was negative prior to switching everyone.
Did they look at Hep B DNA negative?
I did not see that they did that. No. I can go back and look though. Okay. So last, this is a paper that was published out of Mount Sinai, and this is a little bit of a dense table. So I'm just going to go through the snapshots on the left-hand side. And they basically discuss in this paper 4 sort of worrisome cases that I think help to capture for us when we should be thinking about scenarios that can lead to, scenarios that can be troublesome. And they described 4 different patients. And so these are all true. So the first one is someone who was core antibody, and this is all in the context of switching to non-Hep B active active therapy. And they define that as not containing tenofovir or entecavir. So the first one was a core antibody negative person who switched to dolutegravir and rilpivirine and switched because he just wanted to be on a single tablet regimen. He had been vaccinated 5 times, 5 separate vaccines for Hep B. He hadn't responded. No Hep B DNA was recorded, and he was core antibody negative. He developed hepatitis B infection, and this raises and had LFT abnormalities. And this just raises the point that remember that these folks should be vaccinated. He should have been, had this be a trigger when he was changed. A, he should be vaccinated, and B, that you do get a prophylactic effect from being on a tenofovir containing regimen. So we know that people, when they're exposed to hepatitis B, are much less likely to get hepatitis B active infection if they are on a tenofovir containing regimen. So remember that, but I think most importantly, this was a missed opportunity to vaccinate him. The second person was on a tenofovir containing regimen and switched to dolutegravir, darunavir, ritonavir. I don't know what the reason for this was. He had a core antibody negative. He was surface antibody positive 3 years before, but this had gone away. He was surface antibody negative at the time that they were evaluating him. He'd been vaccinated 3 times remotely. No hepatitis B DNA was recorded, although he was surface antigen negative. He also had a new hepatitis B infection after he switched due to an exposure. And I think, again, just raising the point that surface antibody can wane and you can be susceptible to infection even after having a documented surface antibody positive. We all hope that you'll get an anamnestic response and be protected, but that's not always the case. So again, an opportunity for when you check a surface antibody, it is worth revaccinating those folks if they're negative. Then getting into a little bit of the more worrisome place here. Number 3 is a reactivation case. So this is a person who'd been on a tenofovir containing regimen, was prior core antibody, was core antibody positive, surface antibody positive 4 years ago, but that was not rechecked, had been vaccinated 2 times in the past, and there was no Hep B DNA recorded. This individual switched to dolutegravir and darunavir because they had chronic kidney disease, and they had a LFT flare and detectable Hep B DNA, and then were lost to follow-up. So again, someone who had a flare despite being surface antibody positive in the past. We don't know what their last surface antibody was, but they were core antibody positive, and just really raises, your radar about keeping an eye on these folks if they have an LFT flare, and thinking about the role of continuing tenofovir if that would have been appropriate for him, or adding on entecavir, which is tolerated in renal disease. And then lastly, this is just a cautionary tale. This is a gentleman who was on a tenofovir containing regimen and was surface antigen positive, remotely had cirrhosis, although this had been compensated and I think it had fallen off the chart. He was DNA negative at the time, but he was on a tenofovir containing regimen and was switched to dolutegravir rilpivirine because he wanted a single tablet regimen. They say in the paper, the provider just didn't realize that he was surface antigen positive. So that was a mistake, and this can happen. It's a reminder we all need to look and check these serologies. He was DNA negative because he was on a tenofovir containing regimen, and he had a pretty massive reactivation, which led to a liver transplant for him. So I would say in these folks, this is a big red flag. If they're surface antigen positive, they are at risk, and we really need to think through our shared decision-making about what we choose to do with them. So in response to this, when at ID Week, and some of you may have been at this session or seen this, Mount Sinai released some guidance about what they think about how to approach this to avoid these problems. And I'm going to go over how I think we should approach this, but I just wanted to put out there that these guidelines were out there to start the discussion, and that they basically say if you're core antibody positive, surface antibody negative, that you shouldn't switch to non-Hep B active therapy, meaning not containing tenofovir. And if you're Hep B core antibody positive, surface antibody negative, that it's shared decision-making. This is conservative, and I want to put this in the context of the patients that we're seeing. So I'm just going to provide what I think our approach should be, and open to dialogue. And I really appreciate the input that I've gotten from folks on Pop-Up and Splash thus far. So first of all, if you're considering switch or start of a non or suboptimal Hep B coverage ART, and I would say that's dolutegravir 3TC, Dol-Ril, Cab-Ril, or other tenofovir sparing regimens. I know some people use doravirine and dolutegravir in some settings, myself included. Just remember, start off by saying, what are the hepatitis B serologies? I have to have this in my brain. And I would get new new ones if it's been more than 6 months. Okay, and that should include a surface antigen, a surface antibody, a core antibody. If they're core antibody positive, I would really think about getting a DNA to look for occult Hep B DNA. You can argue back and forth whether you need to do this if they're surface antibody positive. Probably just reasonable to do it to be on the conservative side. But remember, if they're on tenofovir at that time, that it very well may be suppressed. So just keep that in mind. But if they're on, Triomec, maybe they will, maybe they won't be. I would put core antibody in the problem list. I can't stress this enough. This is what people look at. I know EPIC is a mess and we all chart in different ways, but at least that keeps it on the radar. We've all seen in the hospital, people have reactivation because rheumatology or oncology or someone just didn't realize that this was the case, and things like Rituxan and high-dose steroids get added on. So just try to make that your practice. If someone is core antibody positive, it means they have Hep B in their body, and we should all just remember that that is something that puts them at risk. Okay, so I redid the Mount Zion chart, trying to contextualize it for the type of care that we're often providing. So first of all, I'm just going to get rid of that thing up top. I don't know if you guys can see it. If someone's Hep B surface antibody antigen positive or DNA positive, if possible, I would treat them with Hep B active ART, tenofovir or add-on entecavir. We always have to, have our care be patient-centered. That's not going to work for everyone, but if we can, I think that's the goal that we should be aiming for. What about people who are core antibody positive, so they have a risk of reactivation, but they're surface antibody negative? Right. Check the DNA. So if they're Hep B DNA positive, I would be very cautious about switching them. This isn't always possible. Some people, the only way they can be treated is with Cabril, and that's all that they're going to take. That's fine. Just be aware that that's the case, and see if it's possible to offer them an oral Hep B active adjuvant to this, like oral tenofovir or entecavir, but make sure it's on your radar and have that discussion. If they're Hep B DNA negative, then I would have shared decision-making considering the possible risk. And then I really want to just make the point that your risk of flare is increased when you're withdrawing Hep B active therapy. Some people come in and they just haven't been taking any medication. They do run a risk of having their hepatitis B progress, but it's less of a flare situation if they aren't on any medications. So when you withdraw medications, including lamivudine and tenofovir, when you can see people flare. And then vaccinate, and I just put a little star here. We could talk about this for hours, but they do recommend vaccination for isolated core antibody positive patients if HIV positive or otherwise immunocompromised. It's not the strongest recommendation. It's probably not going to hurt people. I think it's a reasonable thing to do. What about if you're surface antibody positive, core antibody positive? I think the risk of reactivation is low. It's not zero. I've just showed you some examples of people who did reactivate. I think, though, it should be on the radar with some shared decision-making about possible reactivation risk. But more importantly, we need to remember as providers to just keep checking LFTs, particularly during that first year. And if the LFTs bump, keep this in your differential of the list. LFTs bump for all sorts of reasons, but remember, if that LFTs are going up and they're core antibody positive, think about getting a DNA if you have removed tenofovir or if they're not on a tenofovir or entecavir containing regimen. Gets a lot easier in the last two squares. If you're core antibody negative, surface antibody negative, they should get vaccinated. And remember, we can give Heplosab, and typically 2 doses is enough at 0 and 1 month. We're eagerly awaiting the data for the 3rd shot in people who have been non-responders. I think it's okay to start dual therapy at the time of vax initiation if someone is really eager to get going. The Mount Sinai guidelines say, to wait until you've documented a surface antibody. I think that's conservative, but it is important to document that they have responded. And I think in the current algorithms, that's on the PCP to do that. And then if they're surface antibody positive, core antibody negative, great. They are protected, and you can put them in that safe category as proceed to switch. So I'm going back to our case now that we have that context. Remember, this is a 48-year-old person who's on Triomec, on and off. Their viral load for HIV is detectable, and they're isolated core antibody positive. So I think that it's reasonable to switch them to Cabril and just keep the LFTs on your radar to monitor regularly and have a low threshold to check DNA. And then I would vaccinate them for hepatitis B, but I wouldn't wait to switch them, especially if you think this is going to be the most effective way to get their HIV suppressed. Okay, Diane, jump in.
I'm just going to talk. So thank you. Thank you so much for doing this case, because we think about this a lot, and it's a beautiful discussion. I hadn't seen the case report, but just to say, we have one person in the literature with the HBV DNA where this was a problem, because we don't know in the VA study. That's building from Gabe's point. But I think, thank you for sharing that. It can happen. I mean, I think there's 2 points. I think one is, I don't understand any hesitancy to get an HBV DNA. If it's positive, it's helpful. If negative, it doesn't tell you anything.
Right.
It should be standard. And I see so many cases where people just do it and they're like, well, we didn't do it, or this is a reason to do HBV DNA. To me, it's like, what's a reason not to do it? Because if it's positive, it makes a difference. That's point one. And point two, and I say this in humility with some of the world's unbelievable providers in a pop-up setting. We can't undermine ourselves saying with people who, I don't want to take pills for HIV, because they will take pills for other diseases.
It's true.
And I really think one should go into that. Okay, we know we're not going to do pills for HIV, but for this disease, this is all we have. And we really need you to do this, because there are, once you've seen somebody end up in a hospital or ICU with this is a very serious disease. So once again, all the pop-up providers know this, but I think it's a point worth making.
Yeah, and you can't have that. You have to have the discussion to let the person say, to make that decision. So I think that's why really, when I say shared decision-making, it's really about that education and talking through, hey, do you want this? Can you take this? And you're right that many people can take medications for other reasons, and may choose to if it's contextualized. I totally agree. Yeah. Gabe?
One other question. And this may be not, well, just in this patient in particular who's non-adherent, it seems to have been on and off a regimen containing 3-TC, was not on tenofovir, and has not had Hep B reactivation. Do you factor that in as like, wow, the risk may even be lower, or is it pretty idiosyncratic in that with start and stops at some point you may reactivate? Do you know what I'm asking?
I do know what you're asking. Thanks. I don't think we know the answer to that. And I don't think you can say, well, you've passed that test exactly. But you're not withdrawing tenofovir based therapy. So, I don't know. I don't think we should take reassurance in that one, but I'm glad that it hasn't happened to him. And in most people, it won't happen. But I think to Diane's point, we're talking about the few on the margin who can have a really bad outcome. And we just want to be, do everything we can to try to avoid that and be monitoring appropriately. Because I know when I see elevated LFTs, my list is a long one, and reactivation of hepatitis B is usually not at the top of the list. And sometimes it's not on the list at all. And just want to have that out there. Yeah.
I was just going to tack on to Diane's point that I have a patient with Hep B, HIV co-infection, and switched to Cabrel and entecavir, and is extremely happy. And it just did a lot for stigma, et cetera.
Yeah. Terrific. I'm glad to hear that. Yeah. Okay. I have one other very quick case that I can go through, or we can talk about reactivation. Reactivation is like complicated, and I'm happy to keep going. All right, I'll make this one quick. How about that? It's 9:27. And this was meant to be a fast ending case. Okay, 35-year-old woman, new diagnosis of HIV. She acquired from her male partner, unfortunately. T-cell counts 420, viral load 150. She's wild type. She's surface antigen positive for hepatitis B, E antigen positive, and her Hep B DNA is detectable. She's Delta negative. Don't forget, we need to check everybody for Delta. We do a bad job of that, and we can do better. Hep A IgG is total is positive, and Hep C antibody is negative. And you want to get her started on HIV therapy right away, but you also want to treat her hepatitis B. So here's the question: is TAF? Now I'm just going to raise your hands, okay? And this is evolving. Is TAF better than TDF to suppress her Hep B DNA? Is TDF better than TAF to suppress her Hep B DNA? Or there's not really a big difference between the two, and so this shouldn't be part of your decision making. So one is TAF's better. Raise your hand. Okay. TDF is better. Okay. It doesn't matter. They're okay. All right. This is evolving. But I would say, as of this summer meeting, that I would say there's probably not a difference in Hep B suppression. So these are the data from the ongoing Alliance study, which randomized people to get bictegravir versus dolutegravir with TDF. And initially in this study, what we saw was there was a divergence of Hep B suppression, making it look like Biktarvy-based regimens, TAF-based regimens were better. But what we've seen at this last, when they come out, following people out 96 weeks, this really has come together. together. So I don't see a big statistically significant difference. There isn't a statistically significant difference in the viral suppression. And I think at the beginning, when we saw these data start to get presented, it was like, wow, there's a big difference. Maybe there's something going on here. So I think this is good news. I think it tells us that a TDF-based regimen, if you choose that for whatever reason, is probably going to get you to the same place. There still are some lingering differences between TAF and TDF in terms of antigen loss, which I think are interesting, that favor TAF, suggesting that it might be a little bit better. And then surface antigen loss, there's some numeric differences, but probably not going to make a big difference here. But so my take homes from this is that TAF is at least equivalent to TDF, right? But they're probably both really good. And I know that we're all making really nuanced decisions about TAF versus TDF. So I think it's great we have two very highly active options that we can use. So we don't have to say, oh, you have to take Biktarvy, or because that's the best drug for you. Maybe for e-antigen loss, but I think for Hep B suppression, we're in good shape. So nice to have excellent options. And then I would just say that entecavir is considered second line, but certainly works quite well. But she needs to have TAF or TDF in her regimen. Entecavir, she can't take it, but delighted to see these data evolve. So I will stop there. It's 9:29. I'll turn it back over to Liz and Aisha.
Thank you so much, Annie and Jessica. That was fantastic. Any other questions in the audience in the last minute? Fantastic. I feel one. Okay.
I have one question about, they had talked about at ID week about functional cure, where like you withhold their hepatitis B medication and then like reactivate it and then they got another immune response. And they mentioned that in Asia, that's part of the guidelines that they have there. Did they talk about it at all? This was just one session ID week, and I imagine that the meeting that you were at was a little bit more in depth. Did that come up at all?
Yeah, there's been a lot of discussion. There's been a lot of discussion about that. I wouldn't try to do that in our HAV patients. And I think there's been a lot of caution around doing this. I will also say that the Asian guidelines are way ahead of us in the Chinese guidelines. They're basically like, if you have hepatitis B, you should be treated. And I think that the US could learn a lot from that, and that we should be there too. So. Yeah. Great job. Thank you.